lecture on puberty. Can you all see the screen?
Yes, madam.
Right. So I will.
Madam, the recording.
Yes, I will start it. Thanks.
Okay.
Right. So we will now look at puberty, right? We will first look at normal puberty and then look at uh, situations where puberty can develop earlier or later than usual. So these are the objectives of today's lecture. Firstly, I want you to understand and be able to describe the process and progression of normal puberty. So this is very important. It's a process which takes about 2 to 3 years, and you should know the processes which it entails. Then secondly, we'll look at precocious puberty. That is puberty which occurs earlier than normal, right? So early puberty, abnormally early puberty. How do you identify this condition and what are the possible causes? And thirdly, we'll look at the other opposite of the spectrum, delayed puberty. How do you diagnose or how do you detect whether puberty is delayed and what are the possible causes for delayed puberty? So puberty is a very interesting period in life where you are neither a child nor an adult, right? So it is thought to be a period of transition, the gap between childhood and adulthood. And it's a rather long period. So if you take the physical changes of puberty, they may occur over about 3 years, but the psychological transition actually can take a longer time. So children start thinking and acting, their behavior, everything also changes during puberty. And at the end of puberty, they start behaving and thinking more like adults, in addition to the physically looking like an adult, right? So it is a physiological and physiological and psychological transition from childhood to adulthood. It's a process. And the biggest change that you will notice or observe in a person, individual, is the development of secondary sexual characteristics. That is, in girls, you get a growth spurt and pubertal development and the onset of menstruation. And in boys, you get the genital growth and increase in musculature and the growth. Right. And then at the end of puberty, as I mentioned in the morning, you will stop growing. So that would be the final height that you will then go through adult life in. So that is, you achieve your final adult height at the end of puberty. And puberty is influenced by many factors. So there are genetic variations, and it is affected by the nutritional status, other environmental factors, and also socioeconomic factors also play a role in when people attain puberty and how they and the changes that they undergo to a certain extent. Now, the onset of puberty is still not a very accurately described phenomenon. We don't know what exactly causes or turns on puberty, but we do know that it is initiated by the hypothalamus. So in the brain, you have the hypothalamus, which is associated with the pituitary, and so the hypothalamus-pituitary axis will stimulate the gonad to bring about the hormonal changes of puberty. Now, the hypothalamus-pituitary gonadal axis is actually suppressed during puberty, during childhood. Right. And what happens is when something triggers now that it is now time for puberty, that suppression is goes away and the GnRH starts being produced. So we will look at that in the next slide, but what you have is the gonadotrophins or the GnRH, gonadotrophin releasing hormones, starts um, stimulating the pituitary to secrete FSH and LH, follicle stimulating hormone and luteinizing hormone from the pituitary gland in a pulsatile manner, right? So gonadotrophins are released in a pulsatile manner, and the amplitude of these pulses increase with the onset and progression of puberty. And the age of onset of this phenomenon is dictated by genetic factors and environmental factors, right? So the age of menarche of your mother and your sisters and your aunts will dictate onset of puberty in a girl and in a boy likewise. So boys are more influenced by their paternal genetics and girls more by their maternal genetics, but both can play an influence. Right, so this is a diagram showing the hormonal changes which occur. So starts at the hypothalamic level. So in the hypothalamus, when this inhibition goes off, GnRH, gonadotrophin releasing hormone is secreted at a particular age, right? So say for average 10 years in a girl, it starts being secreted. There is a range, but on average, let's say 10 years. And so this stimulates the pituitary to produce FSH and LH. So the right side shows the development in a girl. So the first two steps are similar in both girls and boys. And then if in a female, you will have the ovary. So the FSH and LH stimulate the development of the ovarian follicles. And the ovarian follicles will enlarge and start secreting initially estrogen and later on also progesterone. This estrogen is the one which acts on the body to bring about secondary sexual characteristics. So there are changes in the external as well as internal genitalia, and outside what you can appreciate during a physical examination in a girl is the breast development. So a child who does not have breasts starts developing breast. And from the onset of, we call it breast budding, from the onset of breast development to completion of breast to a normal adult level, it takes about 2.5 to 3 years, right? So it's a process. And in the meantime, inside the internal genitalia, the uterus also starts enlarging. So we can also do ultrasound scan of the uterus to see whether it is enlarging appropriately. We don't do it unless there is a problem, right? But if you do it, you will appreciate that the uterus also grows in size and shape and becomes a normal adult uterus during this time. And the whole process is actually enabling this individual to reproduce. So reproductive capacity is developed during the process of puberty. So with all these, and then the estrogen, in addition to the development of breast and uterus, it has a direct effect on the growth direct effect on bone lengthening as well as indirect effect by stimulating more and more growth hormone. So in a girl, you will get a growth spurt, pubertal growth spurt and sexual maturation. So these are brought about by estrogen. If you take a boy, if you look at the right side, so the same process happens in the brain. The hypothalamus secretes GnRH, which leads to FSH-LH secretion. And in boys, you have the two testes. So the FSH and LH cause the testes to enlarge in size. So this can be appreciated because the testis is located outside the body in the scrotum. So the first sign of pubertal development that you can appreciate in boys is the testicular enlargement. Excuse me. So we say when the testicular volume, and you can measure it by an oxidometer during a genital examination. So in a boy, if the testis volume reaches 4 milliliters or more, then we can say this child has started puberty. This is from a physical examination. Before that, biochemically, we can check if the FSH-LH has started to rise. So biochemically, the FSH-LH go up, and in girls, physically, the breasts start developing. In boys, the testes start increasing in size. So the testes have two types of cells. They have the Sertoli cells and the Leydig cells. So the Sertoli cells are the ones which lead to spermatogenesis, and the Leydig cells produce testosterone. So the testes produce testosterone, and this in boys leads to the rest of the genital growth. So the testicular volume is increased due to FSH-LH, which that's a trophic hormone, but then the testosterone leads to enlargement of the penis and the scrotum, right? So the genital development as well as the growth spurt. So testosterone, like estrogen, that also affects works on the growth plate of bones and stimulates growth hormone secretion, and both these lead to a growth spurt in the boys as well. In addition, in both genders, you get pubic hair development, right? Axillary hair development, those occur mainly due to the adrenal androgen. So the adrenal gland, it's called adrenache, and pubache is the appearance of pubic hair. That is not directly related to the ovary or testis, but it's part of the secondary sexual characteristics, and it occurs more or less at the same time. They are not directly linked, however. So this is the same thing with a little bit more detail. I told you we don't know exactly what triggers the GnRH, but there is now a lot of work being done in this area, and we know that it's a chemical called kisspeptin, which is involved in the start of puberty, and that in turn, these molecules are affected by central signals like GABA and glutamate, and also peripheral signals like leptin and ghrelin. So for instance, you need to reach a particular weight, you need to have a particular amount of fat before puberty starts. So if you're very thin, if you have anorexia nervosa, you may have heard that you don't start puberty because you don't have the enough fat and you don't have adequate leptin level. Leptin is produced by the adipose tissue, right? So we're starting to understand some of the mechanisms which lead to puberty occurring. Right, so let's look at normal puberty. So the age. Now, you need to remember these, and it's quite easy to remember. So in girls, the normal age at when, if you notice breast budding, you know it's normal, right, is 8 years of age. And breast budding can occur from your 8th birthday up to the completion of 13 years. So anything occurring between those years, that is the onset, we call normal puberty. So girls can start, the onset of puberty can start anywhere from their 8th birthday to the completion of before their 14th birthday, and it is called normal. Boys, it occurs little bit later, right? So it's 1 year later in boys. So say there are twins in the family, you would expect the girl to go into puberty on average about a year before the boy starts, right? That's the way biologically it is happening. So boys enter puberty anytime between 9 to 14 years. And what we mean by enter puberty is that their testicular volume reaches 4 ml or more, right? That's what we see physically, right? So it's very important for you to remember these ages. These can vary a little bit. For instance, you know about the secular trend. So populations are getting taller. For instance, in America, now they say even girls starting puberty by 6 years of age could be normal. That is because of overweight and obesity and early born age. The whole thing is changing because of overnutrition. But these cutoffs are adequate for you all to know. This is what we use in our country. And I already told you what are the first signs of puberty. So in girls, it's breast budding, and in boys, it's testicular enlargement equal to or more than 4 mils. And I'll explain how we look at that. Right. And the other very interesting thing that I really want you to remember is you do have your chronological age. That means the age from your birthday or your birth certificate. But sometimes puberty will correlate better with your born age than the chronological age. Now, if you remember the morning lecture we did on abnormal growth, I mentioned that if a child has constitutional delay in puberty, he saw her born age maybe 1 to 2 years delayed. So you may have a 13-year-old girl who has constitutional delay in growth and puberty. It is a normal physiological condition. So her born age may be 11 years. So for her, it may take, so her pubertal age may be closer correlated to her skeletal age, which is 11 years, rather than her chronological age, which is 13 years. So at 13 years, most of the girls in her class may have started puberty already, but she may be behaving more like her body may be behaving more like a 11-year-old. So 2 classes below her, very few girls may have started puberty, and she may be kind of compatible with them, right? So that is what we say. Puberty correlates very closely with skeletal age. Again, we don't know the exact mechanisms behind this, but it's a well documented phenomenon. So, very useful in clinical practice. So, someone called Tanner described various process where we can stage puberty. So, in girls and boys, we use the Tanner staging to classify their stage of puberty. So in any child, Tanner stage 1 is the childhood. So this is entirely pre-pubertal. So it's very easy to remember. 1 means you haven't entered puberty. And 4 means the normal adult, right? So 1 is pre-pubertal, 5 is completion of puberty. So you have only 3 stages to remember, which are peripubertal. So in stage 2, girls have started breast budding, right? In stage 3, you have the breast contour developing. In stage 4, the areola becomes elevated. And in stage 5, you go back to the stage 3 contour, normal contour, which is larger and of adult size. Pubic hair, likewise, 1, you have no pubic hair. 2, start developing pubic hair. 3, it spreads more, and then so it's a gradual gradient, and by pubic hair Tanner stage 5, you have the normal adult female pattern, right? So you don't need to know this in great detail, but just remember 1 is prepubertal, not 0. 1 is prepubertal, 5 is normal adult, and 2, 3, 4 means the child is undergoing this transition. Right, so what happens in boys? I said onset of puberty is when the testicular volume reaches 4 or more. And we use a oxidometer to assess the testicular volume. When you go to the wards, prof unit, you will see we have oxidometer. It's usually used by the pediatric endocrinologist, right? So this is the measure of the testicular volume. So you use the stereognosis and vision to see assess the child's testicular volume with these beads, which are, this is 1 ml on to 25 ml. So you can see the first 3, 1 to 3 mils is when normal prepubertal child, and then when the testicular volume enlarges to 4, then you know puberty has started. So this distinction is very important. And then from there, so early puberty, mid puberty, late puberty, we don't really go very much by that as well, but this is the process of puberty. And in adulthood, the testicular volume will be 20 to 25 mils. Now, the importance is this, the distinction from 3 to 4 heralds the onset of puberty. And the other important parameter is the boys have their height, the maximum growth spurt, their height velocity, the rapid increase in the height velocity occurs towards the end of puberty, usually when their testicular volume is about 10 to 12. And in the first stages of puberty, they don't have much of a rapid growth. So growth spurt occurs later in puberty. So if there's a boy who's worried that he's short and he has a little bit of delayed puberty, then we know if his testicular volume is still about 8 to 10, then he has potential to grow over the next year or so. Right, and if you look at the Tanner staging, so testicular volume 3 is pre-pubertal, 4 you are in the first stage of peripuberty, that's Tanner stage 2, right? So then there is a progression. Around 10 is Tanner stage 3, around 16 these are just rough measures, Tanner stage 4, and this is the normal adult height. And during that time, you get the penile growth and the scrotal growth as well. So just a rough measure to know which stage the child is at. Right, and then let's move on to the pubertal growth spurt. Now, in girls, the growth spurt occurs early in puberty, right? So it occurs in early puberty in girls, but in more advanced puberty in boys, right? So you will see this phenomenon. The maximum height spurt occurs about 2 years later in boys compared to girls. So there will be a particular time, if it's a mixed school, for instance, all the girls in that class, because they will start puberty 1 year before boys, and they will have their growth spurt in early puberty. So 2 reasons that all the girls in the class may be taller than all the boys, right? If you look back at your childhood, adolescence, you may remember there was a time maybe between 11 to 12 years, right? And then what happens is the girls don't achieve as much height as the boys. So during their total pubertal height gain is about 25 centimeters, whereas boys achieve a little bit more, 28. So testosterone is a more potent growth stimulator in that sense. So boys achieve more than girls, as well as boys have their growth spurt later on. So they have a few more years to grow as children as well. So this leads to that 12.5. Remember I told you when we are calculating mid-parental height for the female, for the mother, we add 12.5 because females are on average 12.5 centimeters shorter than the male. So these are the two reasons why males end up taller than females. So during childhood, there is not much of a difference. And then girls start puberty early. Because they start puberty early, they stop growing early as well. So their height spurt occurs early, and at a particular period they're taller than the girls, boys in the class, same age. But their maximum growth, they grow during puberty is also less, and they start it early, so they stop. They fuse the epiphysis earlier than boys. So we say usually if the bone age is 12 years in a girl, after that she doesn't have much growth left. In boys, they continue to grow till their bone age is about 16. Is it 20 minutes now?
Yes, madam. Yeah.
Okay, thank you. So any questions up to that point? Are there any questions? You can share on chat. No? Okay. Right, so this is the growth height velocity chart we discussed in the morning, and you can see the girls have their growth spurt around 12 years, whereas boys have it around 2 years later, around 14. And then girls stop growing by the time they are 14 to 15, whereas boys continue to grow until they are about 17 to 18, right? So they have a longer time. So during this time, they continue to grow this gap. They continue to have childhood growth, so they end up taller. Right. So final adult male height is greater due to the increased period of childhood growth and increased pubertal height gain. Right. So with that, we finish the normal puberty and we'll quickly look at abnormal puberty. This is not a true phenomenon. This is just a photoshopped image, right? Okay. So abnormal puberty, we have early puberty, precocious puberty, and then we'll look at delayed puberty. Right, so let's look at early puberty. So development of secondary sexual characteristics before the age of 8 years in a girl or before the age of 9 years in a boy is known as precocious puberty. Right, so there can be two main reasons for a child to go into early puberty or precocious puberty. What you mean isosexual is that it happens for the same gender. For instance, if it's a boy, then what happens is the testicular enlargement and the genital growth. If it's a girl, what happens is the breast budding and then uterine enlargement and so on. Sometimes you can have heterosexual, which is opposite pubertal development as well, like in if there's an excess of androgens in a girl, then they may get virilization. I'll talk about that as we go along. Excuse me. Right. So when you take precocious puberty, there are two main categories. One is true precocious puberty, which is also known as GnRH dependent or gonadotrophin dependent, where puberty occurs because the hypothalamo-pituitary axis itself has been activated. So the stimulation comes from the hypothalamic level, right? Then we also have pseudo precocious puberty, where it is GnRH independent. Now, usually puberty starts from the hypothalamus, but there are certain instances where it doesn't start from there. And this is called pseudo or GnRH independent precocious puberty. And some of the reasons could be, for instance, if a child develops a tumor in the ovary or the testes. So these can suddenly start activating rapidly and start producing some hormones. Yeah, it is not activated from the FSH-LH pathway, right? So these are certain, these are called pseudo-precocious or GnRH independent. And it's usually more common to have the GnRH dependent than the GnRH independent. But it's important to know that both of these could be the cause if you have a child who's presents before 8 years with breast budding or before 9 years with testicular enlargement. Right, so first let's look at the central precocious puberty or the gonadotrophin dependent or the true precocious puberty. So there are three terms that they are known as. So this occurs because of premature activation of the hypothalamo-pituitary gonadal axis. It follows the normal sequence. For instance, a child may, who's pre-pubertal, will start, a girl will start breast budding, go on to Tanner stage 1, from 1 to 2 to 3 to 4 to 5, and then menarche occurs usually when the breast stage is more than 4, right? So towards the end, menarche is one of the end results or the end events of puberty. So puberty will occur towards the end. So there is a particular sequence, and what Tanner suggested was that you move from one stage to another roughly in about 6 months. So the whole process takes about 2.5 to 3 years. Now that is, so when you have gonadotrophin dependent puberty, that same sequence happens. It may happen more rapidly, but they will go in that sequence. And central precocious puberty is actually more common in girls. And it's not that uncommon. We have quite a few girls in a pubertal clinic who come with idiopathic central precocious puberty, right? So girls tend to have this without an underlying cause as well. Of course, some of them do have a serious underlying cause, right? But I just want you to remember that idiopathic central precocious puberty, as well as to take central precocious puberty as a whole, it's commoner in girls. Boys tend to have more of the other condition, which is delayed puberty. So central precocious puberty is uncommon in boys. So you always need to investigate any boy who presents with testicular enlargement, right? Because as I told you, the central precocious puberty starts from the hypothalamus. So sometimes this could indicate that there is a lesion in the hypothalamus, a brain lesion causing precocious puberty. Therefore, precocious puberty always needs to be taken seriously. In girls, it could be benign, but you need to be aware that even in girls, it could be due to a brain pathology. Right. So, what are the causes of central precocious puberty? It could be idiopathic. We don't know the cause. Especially in girls, it could be idiopathic. There is no known cause. And we sometimes find that it's familial. So there could be lots of females in the family, maybe the mother, the cousins, the elder sister. All of them may have gone into puberty a little bit earlier than normal. And the way to ask usually is to ask the age of menarche. So menarche occurs about 2 years after onset of puberty, right? So if a child starts breastbudding by 8, you would expect them to attain menarche by, that is the first menstruation period would occur in about 2 to 2.5 years. So that means by 10 and a half, this child will have menarche and regular menstruation. If the onset of breastbudding starts at 12, then menarche would occur roughly around 14 years of age. So the age at menarche, you can get an idea from by asking the family history of the other females in the family and see whether there is a tendency towards early puberty. But the more sinister causes are the central nervous system problems. So the commonest of these is a lesion known as the hypothalamic hamartoma. It's not exactly a tumor, it's a growth, the hamartomatous growth in the hypothalamic region. And we have quite a few children with very early puberty in our clinics, right, who present around 2 years of age, 2 to 3 years of age with this puberty with elevated FSHLH. And so when we do the brain MRI, we find that there is a hamartoma in the hypothalamic region. It usually doesn't need brain surgery to remove, right? So we just manage by suppressing the puberty. And I'll talk about how we do that later, right? But it could also be due to a tumor in the suprasellar region, in the front of the brain, just above the pituitary. If you have a tumor like astrocytoma, that also can cause central precocious puberty. So you have to be careful. Also, children who have had some trauma to their brain. For instance, if they have had previously had a brain tumor and got radiation to their brain, or if they have had a severe infection in early childhood like meningitis or encephalitis, or if they have suffered a severe head trauma in the past, these children also sometimes go into early puberty because some of the structures which is inhibiting puberty would have got destroyed in this process. And also we find that children who have these cerebral anomalies, like sometimes there are kids with very large brains, hydrocephalus, they are born with brain deformities. Some of these children also sometimes go into puberty quite early, probably because of damage to their hypothalamic region, which inhibits puberty. Right. And the other cause is if someone has got chronic exposure to sex steroids, which leads to advancement of bone age. So there is a condition called congenital adrenal hyperplasia. I think you would have learned about it in the endocrine and metabolism module, where children, or both girls and boys, if they haven't received adequate treatment or they have a severe form, then they have more androgens, male hormones in their system. So this advances their bone age. So I told you bone age correlates very closely to puberty, more than your birth year. So if a child had, for instance, congenital adrenal hyperplasia, and by in his 8 years, it's a boy, his born age is 11 years, 3 years advanced, then his body will now start responding to his born age and start going into puberty. That's because his born age is advanced, and the brain, as I told you, is closely linked to the uh, born age rather than the actual chronological age. Right, so this is a picture of a hypothalamic hamartoma. You can see the circle shown by the 4 arrows. So that's just impinging on the pituitary and leading to. So you need to do a brain imaging, a MRI, to visualize these lesions. Then we'll go on to the gonadotrophin independent or peripheral precocious puberty. This is not due to activation of the HPU axis, but an increase in sex steroids by any other source. So it can be endogenous, like by a tumor in the adrenal gland or in the ovary or testes, or it can be exogenous. Sometimes children who are doing sports, though it's illegal, may be taking testosterone or androgen supplements on the sly to improve their speed, their muscle power, right? So they also can have peripheral precocious puberty. So there, it may not follow the normal sequence. We call it dissonance. So, for instance, if there's a girl with a ovarian tumor, she may have breast budding stage 2 and then suddenly start developing menses or irregular pervaginal bleeding. So it's all a little bit not occurring in the normal sequence. We see that in peripheral precocious puberty. This is not in an orderly manner stimulated by the hypothalamus. And then if you look at the FSHLH level, it's very low, it's pre-pubertal. That is why we call it gonadotrophin independent. And so there are several causes for peripheral precocious puberty. So any problem in the adrenal gland, like congenital adrenal hyperplasia, which you have learned about in the ENM module, and adrenal tumors. And then you can have gonadal tumors, so either in the ovary or the testes. There's a rare syndrome called McCune-Albright syndrome, where there's activation of the receptors, FSHLH receptors, which cause the body to go into early puberty. So that's also not originated from the hypothalamus. So it's a peripheral precocious puberty. And then if they're exposed to sex steroids from outside sources, also they can develop early puberty. Features of early puberty, though it's gonadotrophin independent, it's called pseudo precocious puberty. Right. So how do you assess a child who presents with precocious puberty? Let's look at girls. Let's look at boys first, because I said it's always abnormal in boys. It's hardly ever idiopathic. So it's uncommon and almost always warrants further investigation for underlying pathology, including brain imaging. So if you take a girl, it's more likely to be constitutional, but if they are, especially if they are less than 6 years, we would do a brain imaging, and of course we would do the FSH, levels and ultrasound and the thyroid functions, right? There are a few tests, but these are specialist tests, so you need to know when to refer, right? When to refer, the ages and what you have to look for. Right. So if you have a child with precocious puberty, then we look at whether there's a family history of early puberty. And especially you can look for features of increased intracranial pressure, visual fields, right? And evidence of early morning headache, vomiting. And it's important to stage and see for the breast development, for the pubic hair, what the Tanner stage is. And in boys, we check the testicular volume using a oxidometer. Then we do a bone age to see what the bone age is, right? And then FSHLH is a crucial part to decide whether it's gonadotrophin dependent or independent. If it is gonadotrophin dependent or central, then we may consider brain imaging, especially in a boy and also in a young girl. And we would do a abdominal ultrasound scan where we can look at the uterine size, the endometrial thickness, if there are any ovarian pathologies like a tumor. You can look at the adrenal glands and look at the testes in boys, right? So these are few of the tests You take a family history, look for features of brain tumors, you do your Tanner assessment, and then look at the FSH-LH and bone age, brain imaging, and ultrasound scan the abdomen. So there's another condition called premature telarche. Now that is a benign condition and it is more common, right? So it occurs in young girls, young baby girls. So usually between the ages of 6 months to 2 years, little bit earlier than when you see central precocious puberty, and there are no other signs of puberty, right? So there is no pubic hair, there is no growth spurt, and it's a self-limiting condition. We just tell the parents not to touch the area. Sometimes they do all sorts of things, right? Just let the child be. But we follow them up. We will see them every 6 months and make sure that the child does not develop any other features of puberty. If you are worried, we may do ultrasound scan and FSH-LH. But this is a relatively benign and common condition. So should be able to differentiate between premature telarche and central precocious puberty. Premature telarche occurs in little girls, little infant girls with no other signs of puberty, which is a self-limiting condition. But if you have a doubt, you can always refer. Right, then with that, let's move on to delayed puberty. I will stop here for a minute. Right, any questions on central precocious puberty? Right, no questions? Okay, so we'll proceed. Right, so next let's look at delayed puberty, right? So as I told you, delayed puberty is commoner in boys than in girls, right? And while early puberty carries its own problems, delayed puberty usually leads to quite a psychological distress in the affected child. So for instance, this is a picture of a boy, so he's worried he doesn't have beard growth, right? And see the difference between a prepubertal child and a pubertal child. So it is not only their physique, their growth and physical characteristics, but also because puberty is also, change in their psychology, they also feel left behind with their peers, right? Right. So delayed puberty is the absence of pubertal development by 13 years in girls and 14 years in boys. So again, as I mentioned, early puberty is commoner in girls and late puberty is commoner in boys, and it's more likely to be constitutional in boys. There are two reasons for someone to have delayed puberty. So one is if the stimulus doesn't come from the hypothalamo pituitary axis. So that is called hypogonadotrophic hypogonadism. The gonadotropes haven't started. Then it could be a cause in the gonad. That means the ovary could have been destroyed or absent, like in Turner syndrome, for instance, you have streaky ovaries, so those ovaries can't function, right? Or the testes, they've had torsion and had surgical removal of the gonads or irradiation of the gonads, testes, right? That is hypergonadotrophic hypogonadism. So the GnRH analog pulse has been activated and the FSH-LH have gone up, but the gonad can't respond. Then because there is no negative feedback, the FSH-LH goes up and up. So you get high FSH-LH, but lack of secondary sexual characteristics. So FSHLH will help to differentiate whether it's hypogonadotrophic hypogonadism or hypergonadotrophic hypogonadism. So if you have constitutional delay, that means your bone age is delayed and you still haven't. So if you have, I told you the adiposity, fat tissue is also important. So if you have a disease, you have chronic kidney disease and you're very thin, your bone age is delayed. In those situations, you can have constitutional delay or delayed puberty. In those situations, your hypothalamo-gonadal axis hasn't got activated because the bone age is delayed. So those are all hypogonadotrophic hypogonadism, right? Okay. So if you look at the two causes, so causes for delayed puberty where you have low FSH-LH, right? The hypogonadotrophic hypogonadism could be constitutional. So it can run in families or it can just happen sporadically in a child. So you can have constitutional delay in growth and puberty. Children with chronic disease or undernourished children, right? Very common to have you're growing slowly, your bone age is delayed, and you also go into puberty later than your healthy peers. Then if you look at disease per se, right, you can have a problem in the hypothalamo-pituitary region. So there's a disease you may have read in, learned about this, I think, in physiology, the Coleman syndrome, where the GnRH and the olfactory bulbs are not formed properly. So these children have anosmia. With COVID, you will know a lot about anosmia, right? But children with Coleman syndrome are born with anosmia. They don't ever feel smell and they don't have adequate GnRH. They can't produce GnRH, so they don't go into puberty. So one of the questions you can ask is whether they have a sense of smell. Then you can have multiple pituitary hormone deficiency. So with growth hormone deficiency, you can have FSH-LH deficiency, thyroid hormone deficiency, all those together, right? So those children also have hypothalamo-pituitary disease leading to delayed puberty. Children with isolated growth hormone deficiency. When you have isolated growth hormone deficiency, if you haven't treated it, their bone age is very delayed, to about 3 years delayed. So when the bone age is delayed, they can not go into puberty at the same age as their peers. And you can have children who have isolated gonadotrophin deficiency. So they have a problem in producing FSH-LH. And finally, the dangerous thing, sometimes due to intracranial tumors also, which are affecting the pituitary region, you can have delayed puberty. Things like craniopharyngiomas. So there could be problems in the brain, which is causing hypogonadotrophic hypogonadism. So children with thalassemia, you will meet a lot of children with thalassemia when you come to the wards. So they can sometimes have, they have chronic disease, they have chronic anemia, so therefore they can have delayed puberty. They can also have this iron overload affecting or destroying their pituitary. So they can have hypogonadotrophic hypogonadism. So anything destroying this pituitary axis or any constitutional delay or any chronic disease. So when you look at delayed puberty due to gonadal issues where you have high FSH-LH but the gonad can't respond, then those are the syndromes. You have heard of Klinefelter syndrome. These are very tall boys who have gynecomastia and don't go into spontaneous male puberty. Then you have girls with Turner syndrome. Their ovaries, they have streaky ovaries, so they don't go into puberty, right? So all of them have gonadal issues, so they have high FSH-LH. Then if you have a problem in the sex steroid hormone pathway, especially testosterone, if you don't have an enzyme which you need to produce testosterone, then you will not go into puberty, but your FSH will be high, SH will be high, LH will be high, but you can't produce testosterone. And sometimes you may have damaged your gonads due to radiation or chemotherapy or due to some surgery in the region or torsion. And sometimes children with thalassemia, their gonads also can get damaged secondary to iron deposition. So children with thalassemia can have both delayed puberty due to hypogonadotrophic hypogonadism and hypergonadotrophic gonadism, right? So what you need to remember is anything where the gonads can't produce the hormones necessary for the secondary sexual characteristics, they will have delayed puberty. They will not go into puberty. So in these situations, we have to replace the hormonal, the pubertal hormones, the sex hormones, what you call hormone replacement therapy. This we do in adolescents when they are peers go into puberty. If we know they have had a disease in the gonads, then we start boys on testosterone injections and girls on estrogen tablets. We start it very gradually and increase over 3 years, so mimicking the normal pubertal phases, and these children will undergo normal puberty outside, right? Their brain development, the psychological development, and their physical development will progress if we give the hormones from outside. However, they will have issues with fertility if their gonads are damaged. But the puberty, we can mimic it by giving the sex steroids from outside. Right, so very briefly, you know how to assess delayed puberty. You do the puberty staging. You can ask for the sense of smell. You have to exclude chronic disease, very important. Look at the bone age and do the FSH-LH. Then you can also look at the sex steroid levels, testosterone and estrogen. If there is a suspicion of low FSH-LH, you can proceed with pituitary function test and brain imaging. You can always do ultrasound scan of the abdomen and pelvis. It's a relatively accessible and test with no side effects. And if you suspect things like Turner syndrome or Klinefelter, you can do a genetic test and check the karyotype. Right, so in summary, we described the process and progression of normal puberty, and we learned how to identify precocious puberty and the possible causes, and how to identify delayed puberty and what are the possible causes. So you can look at illustrated textbook of pediatrics, right? The second one is the book I use for reference, but for your for third years, I think if you can get hold of a copy of the illustrated textbook of pediatrics, that will be more than sufficient. Right, I have a few more slides if anyone is interested, right? Just a few more slides, just a few pictures and a few slides which just for interest sake you can go through. Right, so if you have a child with delayed puberty, again, you have to identify the cause and manage accordingly, right? Now, the psychological impact of a child is very important. And sometimes even if they have constitutional delay, we try to give them a push start. So you can give them a couple of injections, 3 to 6 months, monthly injections, and this can push start. So you actually trigger the hypothalamus-pituitary axis to start working. But if it's a permanent cause, then we have to start them on long-term hormone replacement therapy with testosterone for boys and estrogen and later progesterone for girls, right? Right. Okay, so that's all for this lecture. Right. Do you have any questions? Okay, there's one question. Are the children with Klinefelter Turner syndromes expected to show normal puberty even though it is delayed? Are they expected to show secondary sexual characteristics? So it's a good question. It depends on the degree of the gonadal problems they have. So there are children with Klinefelters, boys, right? So Klinefelter is always a male. Boys with Klinefelters who can start puberty. Some of them can actually they can develop all the secondary sexual characteristics even, but as young adults, their gonads stop working. So some of them may not need hormone replacement therapy as children, but maybe later on in life they may need it. Now, girls with Turners, if it's full-blown Turners, where all their cells are X, then they have streaky ovaries and they hardly ever go into normal puberty. So for them, we have to start the estrogen around 12 years of age. That's the recommendation. If you have Turner mosaic, that means you have some cells which are XX, but only some cells with the Turner genotype, then some of them can go into spontaneous puberty. So we watch and wait. So if we know there's a child with Turner syndrome and they're a Turner mosaic, for instance, we watch at 14, we start seeing them in 3 to 6 month intervals. And when if most of their peers have gone into puberty and they're not starting, we can do ultrasound, FSHLH, and if it seems like they're getting delayed, then we know they have underlying problem and we will start at that time. Then with exogenous steroids, is there a risk of tumors? Right, I think the question probably is if a child is taking estrogen due to whatever reason or testosterone, does it cause a tumor in the gonad? I think that must be the question. No, it doesn't cause tumors, but it can cause a lot of other health effects. Now, if a girl is taking testosterone, she may have a deepening of her voice, and then there are, everything, their real puberty may get delayed, right? So, and their metabolism is deranged. So it's a very dangerous thing to take this. It's illegal as well, but it doesn't cause tumors. It can cause liver tumors. High dose testosterone is associated with liver problems. So there are side effects, but I think it's beyond the scope of this lecture. Right. If estrogen is needed for closure of epiphysis, then how can it be needed for pubertal growth in girls? So very important. Yeah, I'll come to that. It's a very good question. With normal development, can there be shape abnormalities with sex hormones? Okay, so I think probably not sure what the last question is. Can there be shape abnormalities with puberty? Not quite sure the last question means. Right, so let me talk about the growth, right? So now in girls, estrogen leads to bone growth. It also leads to epiphyseal fusion. So at a particular degree of estrogen, they fuse. It's strange. Again, as you say, it's a very good question. We don't know why estrogen causes growth and causes it to fuse. But the bones mature. What you mean by mature is the epiphysis. The epiphysis actually calcifies more and more. And then actually when it's very calcified, it fuses. So in a sense, when you look at it, it makes sense. It just grows and narrows and narrows and fuses. So in boys also, estrogen is the one which causes the epiphysis to fuse. So boys, in the peripheral tissues, testosterone is converted to estrogen. That is why in early puberty, boys get physiological gynecomastia, right? They can get a little bit of breast budding in early puberty. That's a normal thing. But as the testosterone goes up and up, that resolves. So boys also have a little bit of estrogen, and it's actually the estrogen which causes the epiphysis to grow. Now we know this because of very interesting conditions. So there is a condition called aromatase deficiency. Aromatase is the enzyme which converts testosterone to estrogen. So there are boys with aromatase deficiency. So they cannot produce estrogen in their body. They will continue to grow. They will not stop growing. Even at 30 years, 40 years, they will be slowly growing, right? So because these people with these abnormal conditions have helped us to understand the role of hormones, right? Without enlargement of pelvis in girls and without widening of shoulders, can there be shape? Okay, right. So I think the question is, second question, the last question is about somatic growth. And that's also an important question because people sometimes come and ask us this. So for instance, there are some females who have very excessive breast development. So to an extent that it becomes a physiological discomfort and a psychological distress for them. There are some people who have very minimal breast development. There are people who have minimal beard growth. There are people whose musculature is less. So, how each individual responds to sex hormones, again, there is individual variation. And there's nothing that we can actually do to manipulate that. For instance, I have a 16-year-old boy, a patient who comes and he doesn't have much facial hair. So he's very worried about it, but he has gone into full puberty. So his puberty, his testosterone levels, everything is normal, but he just doesn't have facial growth. So there are individual variations like our skin color, like our IQ level. The response to sex hormones is also different. So each person will have his or her, even the body distribution. Estrogen usually causes fat deposition in the hips. So you get the female body contour. In boys, the shoulders widen and there's more musculature. That also, there is a wide variation, right? So it depends on exercise, nutrition, genetics, family, body distribution patterns, so many other things. So there are a lot of confounders. Any other questions? So I'm not recording now, right? So this is just for you all. Was the morning Zoom lecture uploaded? I sent it to a colleague of mine. I don't know whether she had sent it quite late. Was it uploaded, Rosiru or Maheshi?
Yes, madam, it was uploaded.
Okay. So it's uploaded as one lecture or 4 short segments? Not sure.
Segment wise, madam.
Right. Okay. Yeah. So is that clear? The mid-parental height and those things, I was wondering whether, I think it's a little bit hard for you all because you all haven't seen patients. That's why I usually do it a little bit faster. I hope you all understood. Any other questions? Have I answered all the questions? Estrogen. Yeah, so very good questions. I think you've been listening well. Now the other thing, if you usually make it a little bit more interesting, but when it's a recorded lecture, I didn't. But it's very interesting if you look at puberty, right? And so it's important when you all are doctors also to appreciate how adolescents change with puberty. So, for instance, I'm an endocrinologist, I'm a pediatric endocrinologist, so I've talked with lots and lots of kids with delayed puberty, early puberty, and normal puberty. And so, puberty, their brain development is, it's adolescence, there are phases, and you need these hormones to go through those phases. So, if, for instance, if I have a child who's 14 who has some disease in his gonads, maybe they were removed and they lived in a faraway place, and they may come a little bit late, right? They may come they have a delayed presentation. So these children, the way they behave, they are very childlike. Your brain, so with the sex steroids, your brain also changes. It's called pruning. You have during adolescence, your brain prunes. And things like, so initially in early adolescence, what happens is people start, so your peers become very important. So if I have a child who has delayed puberty, and so maybe in grade 9 or 10, and the others are in puberty, so they'll all be, in cliques. The girls will form one clique, the boys will form one clique, and this child will just not see the sense in that because he's more used to just playing with everyone. And so you have your peers, your same gender, you start making cliques, and then you start differentiating from your the opposite gender. You start to feel the difference more, and then you gang up with your own gender, and then later on you start interacting with the opposite gender where there is more attraction, and all those things also occur with this puberty. If it doesn't happen, those don't happen. And later on in mid-childhood, you start getting attracted to the opposite gender, right? And then in late adolescence, you start one-to-one mature relationships. So sexual attraction and all those also are part of this pubertal process. So it's all about, getting ready for reproduction. And with that, there are other things like taking independence, taking decisions, developing your self-esteem, gaining more responsibility towards your studies. Everything changes, and it's really interesting because for instance, that's why we now start even girls with Turner syndrome, even if they present around 12 years, we start the sex steroids. We know if we start sex steroids, the epiphysis is going to fuse in 2 or 3 years, so they will stop growing and they may be short. But still, if we delay the sex steroids, then they can't relate to their peers. They don't have their social development. Their psychosocial development is hindered. Very interesting how much of it is psychosocial, right? So adolescence and puberty, is a lot of psychological things going on. It's not only the sexual characteristics. Okay, one new message about morning lecture. Can achondroplasia be passed on to offspring? Yes. So achondroplasia and hypochondroplasia are both autosomal dominant diseases, right? So of course, if you have an affected parent, then you can diagnose it as achondroplasia. But about 80% of people develop achondroplasia as a new mutation. So their parents have normal genes. They may have a problem in their germ cells, or it can be a new mutation which occurs during conception or a little before. So the individual achondroplasia has an autosomal dominant gene and a normal gene. Because it's autosomal dominant, they will manifest the disease. So if he or she marries a person without the disease, the offspring, there's 50% chance that they will have the disease, 50% chance that they won't have the disease, right? So half the children will have achondroplasia, half won't. Again, it's 50% chance for each child. Okay, right. So it's 4:12. 3 more minutes. I can give you 3 more minutes if you have any questions. Do you have access to a CHDR? I mean, did you get it in a lecture? Did anyone go through the CHDR with you during a growth lecture?
Yes, madam.
The growth charts?
Yeah.
Do you have slides of that? The 5 to 18 height, weight, weight for age and height and the BMI and height for age charts. You have those on a PowerPoint slide?
Madam, CHDR was uploaded to the LMS.
That's wonderful. So
So,
please have a look at that,
yeah.
right? Because the things I showed you, I've used the CDC charts, but actually you can plot it on the 5 to 18 chart. So there is a chart 5 to 18, which is height for age. So that's the same thing. So you can plot a child's height follow the height from 5 years up to 18 years, and you can plot the mid-parental height at 18 or 19. I can't remember I think it was 19. At that last point, you can plot the mid-parental height, right? Okay. So then, in the absence of any other questions, I will stop the meeting, right? Okay. So thank you for listening, and we'll upload this shortly, right? Maybe tomorrow I will upload this onto the internet.
Okay, madam. Thank you, madam.